Thank you.
Our last presentation is from Charles Coombes, Imperial College of London, and will be titled Study of samuraciclib, a first-in-class oral selective inhibitor of CDK7 in combination with fulvestrant in patients with advanced hormone receptor HER2-negative breast cancer. Dr. Coombes, welcome.
Yeah, it's a difficult one, isn't it? not my fault. Now, how do I get this? There we go.
There you go.
Okay. So, thank you to Carlos Arteaga for giving me this opportunity to present samuraciclib. So, there is an urgent need in metastatic cancer, which is ER-positive breast cancer, for treating patients who become resistant to CDK4/6 inhibitors. And you'll have heard over the last few days, some of you, that on average, we get about a 2-month progression-free survival with fulvestrant in patients who become resistant to CDK4/6 inhibitors, and even with elacestrant, we find that this is only about 4 months. We made a compound which is an inhibitor of CDK7. This was made at Imperial College in London. This compound is an irreversible antagonist. It's an ATP-competitive selective inhibitor of CDK7. It synergizes with endocrine therapy, and you can see in this slide on the left that you can see that the dark bars are the combination of samuraciclib with tamoxifen. You can see an increased effect. And in the middle, you can see the light green represents a combination of samuraciclib, the CDK7 inhibitor, with endocrine therapy compared with the red and purple, which show a less effect. And on the right side, you can see a Western blot that illustrates the important mechanism of action of CDK7 inhibition in ER-positive breast cancer cells. So it has 3 effects in these cells. First of all, it inhibits serine phosphorylation of the estrogen receptor, and as you know, that prevents ER activation. And this is important because work that we published many years ago means that if you have CDK7 upregulated in a situation where you have tamoxifen, a SERD, or low levels of estrogen, you get an amplification of estrogen receptor activity, which is suppressed by CDK7 inhibition. So secondly, you can see that it inhibits CDK1, so that's a second mechanism of action. CDK7 kickstarts the cell cycle by phosphorylating CDK1, and you can see that that is inhibited. And then further down on that Western blot, you can see it inhibits serine phosphorylation of RNA polymerase II. And so that's a third mechanism of action where it inhibits transcription, principally from superenhancers, which are, as you know, a feature of cancer. So we designed a study in which we took 31 women who had become resistant to CDK4/6 inhibitors and endocrine therapy, and we had already established the optimal dose of samuraciclib as being 360 milligrams a day. So we gave them this combination. You can see that the patients that we treated were heavily pretreated. All of them had received CDK4/6 inhibitors and endocrine therapy. A quarter had received chemotherapy. And I just want to show you that 80% had visceral disease. We excluded bone-only disease because patients had to have had measurable disease. Now, this shows the effect of the treatment with samuraciclib and fulvestrant. Now, I'd like you just to look at the horizontal axis there. We have several patients going out beyond 6 months. The vertical red line to the left is the median progression-free survival in SOLAR and also Veronica studies. So you can see that this combination appears to be highly active. The dark green line represents patients with liver metastases, who don't appear to do so well. But the major determinant we found was, in fact, p53. We measured p53 in cell-free DNA, and the orange bars there represent patients who have mutant p53, and you can see that nearly all of them fail to respond at all to the combination of the CDK7 inhibitor plus Faslodex. And that's highlighted on the waterfall plot. So on the left here, you'll see in blue the patients who progressed on treatment, and you can see that most of them had p53 mutant. On the right, you can see the green is the patients who clearly responded to treatment. None of them had mutant p53, and nor did the patients in yellow who derived a benefit from the treatment. And this is shown here, the median progression-free survival you can see in wild-type p53 patients is substantial at 32 weeks, and in mutant patients, it is much less, so less than 8 weeks. I think a very important point in this study is the clinical benefit rate. Overall, the clinical benefit rate at 24 weeks was 35%. But in patients with p53 status, if you exclude patients with mutant p53, the clinical benefit rate rose to 53%. Why is p53 so important? We believe that p53 reacts to the stress induced by CDK7 inhibition. You can see on the right the work that Simak Ali and his team have done to try to understand this, that essentially p53, when it is wild type, responds to CDK7 inhibition to induce apoptosis and senescence. Now, this is important because at this stage of the disease, in ER-positive breast cancer, nearly 70% of patients still have wild-type p53. So the potential is quite great for this combination. The other, of course, is the other negative factor was the presence of liver metastases, which I've already shown you. And obviously, this factor needs to be taken into account in designing future studies. But you can see that the median progression-free survival without liver metastases was quite extensive at more than 48 weeks. In terms of adverse events, the main adverse events are gastrointestinal at the moment. Now, when we began the study, we did not have a routine antiemetic or antidiarrheal protocol. But as we continued through the study with multiple investigators, we now routinely give 5-HT3 antagonists with this compound, which certainly ameliorates some of these effects. We're also developing a further tablet form of the medication, which I think is going to improve matters. But I think a very important feature is that we saw, and this is completely different, obviously, from the CDK4/6 inhibitors, we didn't see any neutropenia or significant myelosuppression in any of the patients. So in conclusion, I think we do have an effective combination here. It is early days, obviously. This is only a small study of 31 patients, but the combination appears effective, particularly in patients with wild-type p53 status, which is measured by cell-free DNA. And we think, and there's no reason to suppose that we did this study with fulvestrant, but there's absolutely no reason to suppose that some of these oral SERDs couldn't be given in combination with samuraciclib to try to improve progression-free survival in patients who have this devastating form of metastatic breast cancer after CDK4/6 inhibitors. And I think it's for this reason that 6 weeks ago, the US FDA granted the drug fast-track status. So this short 10-minute presentation represents a total of 25 years' work by my team. All of it has been funded by Cancer Research UK, including the biology, which was carried out by my colleague Simak Ali, and the chemistry by Professor Tony Barrett and Matt Fuchser, and many, many other colleagues. But I would particularly like to thank the patients who took part in the study, and many, many doctors and nurses that contributed to both the phase 1 study and this study in ER-positive breast cancer. Finally, I'd also like to thank Carrick Therapeutics. We licensed the drug at an early point to Carrick Therapeutics, and they have been really great colleagues to work with. And I think their role in the development and finding the position of this drug has been exemplary. So thank you very much for listening.
Thank you for an excellent presentation. Talk is open for questions now. At the microphone.
Thank you. Very nice talk. Sushin Tan from Mississippi. As you know, the problem with CDK4/6 inhibitors is that we don't have a predicted biomarker. And I'm glad to see that you are able to identify p53 as one of the negative biomarker for CDK7. So my question is, do you know, besides p53, did you look at any other predictive biomarker, including perhaps the expression of CDK7 as a predictive biomarker?
Okay, so, well, let me just answer that, a couple of things first. We've looked at PIK3CA and ESR1 mutations, and we find that that is not neither of that is a predictor of response, wild type or mutant. In terms of CDK7, we've published a few years ago in, I think, Cancer Research, an extensive study of CDK7, MAT1, and RNA polymerase II, and TF2H in breast cancer. This is a ubiquitous enzyme which is needed for every cell type. And although we found it upregulated compared to non-cancer cells and normal breast tissue, I wouldn't say that it would be a useful marker at the present time.
Thank you.
Okay, thank you. There's several questions here in the Sligo asking the future development of this drug. Is it to be, or do you imagine it being done after CDK4 inhibitors in conjunction with CD4 and 6 inhibitors or instead of CD4 and 6 inhibitors?
Okay, so the answer to that is that at the moment, we're focusing on the post-CDK4/6 inhibitor area. In other words, patients who have received CDK4/6 and become resistant to it, which is, I think, the urgent need at the moment. We all agree.
Okay. Lastly, a couple questions about the prognostic importance of p53 mutations. They are likely, those tumors are often not responsive to other therapies, including fulvestrant. So do you see a utility in keeping with the ctDNA we just heard to be measuring ctDNA for p53 and selecting therapy based on that?
That is a difficult one. All that I can say is I know there is a very small literature on p53 and likelihood of response to fulvestrant. I think if you drill down into that literature, it is quite sparse, actually. I'm not entirely convinced by that. But to my knowledge, if you look at the relationship between mutant p53 and success of other treatments, I am not aware. I mean, I'm prepared. I'm not a p53 expert, but I'm prepared to be corrected. But I'm not convinced that there's any other drug treatment that is so clearly related at this point in time to p53 status.
Okay. Well, thank you very much. We've had a fabulous general session, and I wish everyone a wonderful conference the rest